I'll try to represent our group. I was in the omics group. We had a broad-ranging conversation, lots of conversation about, we called it omics because it started with genomics, it could be blood omics, and we had talked about where we thought the big areas of need are. One of the things we thought or said is, what were some of the themes we heard today? And the themes we heard today that were, broad risk of a population group. We heard fear, doctors or clinicians not wanting to order genetic testing because they're not sure what to make of some of the results, including some of these variants that might not be I'll call it, nicely was phrased as genomic uncertainty versus variants of unknown significance. There's a conversation about getting people across the disease spectrum. How do you change behavior? Some of the other conversation is when to test, or how do we build these triggers? We also had a conversation where people highlighted for us that that different conditions lead to different interest in genomic testing or omic testing. So obviously, if you come in with a heart attack or you have a big dissection or an aneurysm, people have been taught that maybe we need to test, not always with a heart attack, but maybe with that, so we could say where that needs to be. There was a lot of conversation in our group about, if you structure or write an RFP and we're in the group, what are these big unmet needs? And so we took some notes. I'm going to walk over and just describe the notes from our session in a second. But I think the way we got to at least what we thought is just that we sort of were talking about these themes that we heard today, and then we got to gaps. What do we not know? What are the big unknowns? And that gaps conversation for a pilot, recognizing a pilot granting mechanism is to get a little bit of support so that somebody goes to answer a bigger question. The gaps that we identified, which I'll talk about right now, were, I'll just step over here, I took some notes. Lack of diverse populations or representative populations in the genetic or genomic groups. A lot of models, but not validation of those models. So a lot of people say this risk score does this, that risk score does that. Not inclusion of people across the whole disease spectrum, so either they've had the event or they're screening, but not across that. Including and ensuring that their patient-reported outcomes and potentially tying those patient-reported outcomes. When you learn about I termed it infoomics, like when you learn information, does it change your behavior? How could we do that? Are there going to be things with AI or other things that move that? Reducing this omic uncertainty and then trying to employ, or when do you do personalized testing? So we thought, from the omic group's perspective, an RFP that looked to address one or more of those gaps across multiple things, and then given that it's a pilot, we also wrote that it should leverage existing infrastructure, so that if you're already doing a study or you have a team doing things, with this pilot help you get to some population you don't have, answer a question you don't have, because there is a 16-month time limit, or we're trying to get a deliverable. So we thought about it in a sense of how do you get to big areas where the field is trying to answer them. You're going to, of course, have to leverage data, potentially AI and other things. But as Vascular Cures, it's a patient-centric organization. We want to make sure it's a patient-centric question and it speaks to somewhere across that risk. So before I give it to one of you guys, anybody from our group, a lot of you I see out there, feel like I didn't represent any of our thoughts, feel free to throw tomatoes or Diet Coke cans, whatever's up there. I see some thumbs up. Everybody good? Okay. Mike, I'll hand it over to you.
Just a question about, because
yeah, sure. Let's talk about that.
The framework of sort of omics kind of projects. Were you guys mostly talking about leveraging data where the omics is already done?
Yeah.
Or doing new omics on defined subgroups of patients with vascular disease?
We left that open, obviously recognizing feasibility for a small pilot. How much can one do, right? But we recognize that there are groups out there doing lots of testing potentially, and they might have validation cohorts that haven't done, so you might be able to get into a different group, so it might already be done. And that pilot or that grant might actually score better than somebody who says, I'm going to go try to enroll 1,000 patients from diverse backgrounds, because we just know how hard that might be. However, we also wanted, given where we were, to stay open-minded about it. Somebody might say, well, we're going to do a very small pilot, but we're going to do it in this population that doesn't get genetic testing, and we're going to study what their questions are, how they get the information, because in the omics space, there was a lot about what we heard was how people process that information or how they change their behavior will be really critical, especially if you want to go to large scale. So you might start with the small scale where you're tying patient-reported outcomes to information rather than I've found this allele and this allele means the same in this population versus that.
Just thinking about, for some of you in the room will maybe be asked to review also some of these proposals. So when we're thinking about, feasibility and statistical design and power with omics, it gets very challenging. So thinking about how to approach some of that, one is, I guess, some sort of case control where a lot of the stuff's already in existence, or I don't know. I mean,
That's one we thought of. We thought like if there's a large set of data, but it's in European ancestry, and now you need to get some amount of samples in a non-European ancestry, then this RFP would not only help with that potentially, but then now make the grant that goes forward, and validation would be captured, and you might have something about how these patients or people are hearing this information. So depending on the condition, we thought that would be a way that you expand where the current features are. But that may not be the only way, right?
Other thoughts or questions in the room, just who wasn't in that room but has interest in the omics spectrum?
Yeah, Mohammed? It's a great question. We spent some time, just in case you didn't hear me saying, is it disease pattern? Is it aorta? Is it different? We tried to answer that by calling it broad population risk, because we didn't want to say it has to be only in the aorta or it has to be in the carotid or it's in the lower extremity. But we did think you might take young people who have no disease or a lot of disease and old people who have no disease. You might find this spectrum risk and then say, in the perfect proposal, not that it exists, but you might have a condition where there's huge variation. You find the outliers, and they happen to be people that haven't been tested before. That would be really valuable in this space. But we didn't say it has to be CLTI versus aorta, because we didn't want to limit the people that might come to us with a condition of interest. Yeah. Yeah. Yeah, great question. Just so everybody, make sure everybody heard. Are you pointing, I think you're saying, Manesh, are you guys pointing to saying you got to be more than one? Are you going to do that? And you're right, like that came into when we were doing all this pie in the sky, and Isabel was like, this thing's got to be done in 16 months. And we're like, okay, yeah, got it. So an important feature of what we're trying to do is leverage existing, what we said, infrastructure. But those could be collaborations, could be data sets. We want you to be creative, right? Because it's not high risk or high reward, but this is an area where we want to fill out an opportunity for a consortium or for people to get to a grant that really matters. So if there are ways to go directly to people of need, maybe that's an interesting way to think about it.
I mean, another way to think about this is sort of an R21 exploratory type of science and or even a planning grant kind of mentality. R34 kind of, what would you need to generate to show that asking a bigger question is scientifically valid and important enough? And I think that's what we want to be able to catalyze. So if you take it from the framework of how would you support your idea for a clinical trial, or how would you support your idea for a cohort study, or an R21 to show a new biomarker, it's usually a 2-year mindset. But you're right, I mean, one of the challenges is sort of the sharing part of it has become more challenging. So at the end, though, I think if it's just data, de-identified data ultimately that people are sharing, that's less of an issue than actually transferring materials. It gets to be more challenging.
Yeah, I think that's absolutely right. The other way we thought about it is if there's ongoing studies, planned or ongoing, whether there's an intervention or not, you could put an RFP to say, hey, I would like to test this in this ongoing population. I found a group doing it, and that helps me get enough baseline data to get to an R or a K or whatever your people are interested in, where you are in your career. So I think that's an important piece. We at least in the omic room, it's almost not conceivable that you could do it all by yourself with that time frame, money, or issue. So you're going to have to leverage something, whether it's existing studies, collaborations, pre-existing data. And the world is a lot of people being really creative out there, so we were trying to be broad yet sort of directive on the omics space.
So our group focused mostly on peripheral atherosclerosis and, sort of unmet needs that related to precision medicine. And we started out by just thinking about three different sort of broad buckets. One is identifying disease, if you will, sort of screening or identifying people at risk for disease. Two is developing better prediction for trajectory of disease, who's at risk of getting into trouble over time. And three was response to intervention questions. And we were, in a way, largely motivated also by Jim, who basically said, well, how would it change what you do for me? Like, what would you do with this information? How would my care be different? And so that really got us more focused on the middle question, I think, overall, which is that, we don't have a Framingham risk score for amputation or for progression to limb-threatening ischemia. And so how could we generate something like that? And we thought about the fact that today, with all the data we have, we wouldn't need Framingham. We would just go backwards from the data and define the village of Framingham if we could figure out, where it was. So we could do it maybe based on existing EHR. So we talked about really a couple of different ideas. One was looking backwards using EHR-based data, defining cohort of interest, perhaps being people who had events, major adverse limb events, and then thinking either about imaging findings that they may have had in the past, non-invasive laboratory findings, and of course combined with other clinical data, and to try to derive or suggest an associative score that was based on sort of a case control approach. The other big approach that we thought about was leveraging existing rich clinical trial data, such as that from Fourier and Voyager and other trials. We recognize that there hasn't been a really large, well-done, prospective cohort study focused on PAD. And it may be a large lift to get NIH to ever do that. It's a 10 or 15 or 20-year project. But in the era of EHR and AI, and also large clinical trials, can we sort of ask that question in reverse? So the clinical trial data sets are very specific in what they have. They don't have as much total richness as the EHR, but they have very clearly defined measurements, and some of them have biosamples available. So a number of thoughts in the group were how to leverage potentially the biosamples and the endpoints already defined in some of those trials to test new biomarkers or to try to validate different predictions. And then the third general area was to think about people who were either asymptomatic or mildly diseased and basically leverage think about how they entered into from the non-invasive lab. So looking at people who just had non-invasive studies, looking at them maybe 5, 6, 8 years ago and defining a cohort based on that and trying to find out who progressed or who didn't progress, with just sort of an agnostic entry criteria of having an abnormal ankle pressure, toe pressure, ABI, any combination of the above, and trying to develop a risk score based on that. So those are three sort of general ideas about ways of getting at a PAD prediction risk score that I think would be, a great goal and a lift. And then we did talk a little bit about response to intervention, although I think there's a lot of discussion around it. People had some ideas about specific procedures, trying to define some specific risk factors and or modification, or what's happening actually to the patient in a treated artery that might clarify the specific role of certain interventions. The data sets for that are probably a little bit harder to sort of leverage retrospectively. That might require some intentional prospective design. But because the event rates are not small, it probably doesn't have to be huge either.